Fertility Matters, Ireland's newest fertility podcast, brought to you by ReproMed.
You're very welcome to Fertility Matters, Ireland's newest podcast delving into all things fertility. Fertility Matters is brought to you by ReproMed, the leading fertility and IVF clinic in Ireland. I'm Susan Keogh, and today I'm joined by Aoife Corley, Clinical Midwife Manager, and Claire Moran, Laboratory Manager at ReproMed. Thank you both for joining us today. We want to start, Aoife, I might come to you first, I guess. You know, information is power for a lot of people when it comes to fertility. As midwife manager at ReproMed, what do you say to people in terms of getting their ducks in a row, or at least giving them the information to know where they stand in terms of how much time they might have left if babies are on their radar? Is it something that people should know where they're at?
I think it is important, and especially with our current lifestyle. You know, we are putting off having children till a later age, and sometimes by the time people come into us, it is, you know, their mid to late 30s. Their options mightn't be as many as they might have been even 5 years previous to that. So I think if we can kind of get the message out to say to women, especially in kind of their early 30s, they're not in a position to have a baby, or, you know, they're thinking about it might be something down the line, it mightn't be something for them, but they don't really know, to get kind of basic information on their fertility status, you know, what their AMH is like, which is their ovarian reserve, if that's in a good place. There's no magic number, but if that's kind of reasonable, well, then maybe they mightn't look at it again for another year or two. Whereas if that number comes back, it's a little bit worrying, maybe they might look at other options. Even if they're not in a position to have a baby, they might look at, you know, fertility preservation.
So is that a pretty straightforward, easy enough conversation if somebody's listening or watching us now, and they're thinking, yeah, you know, I want that information. I want to I don't want to leave it until it's too late. I want to know where I stand. Is it as straightforward if they come to ReproMed? Would that be the first port of call for those couple of initial tests?
That would be one of the main tests. The AMH is something we actually offer pre-consultation, so that we have that number back before you meet with our doctors. They'll be able then to talk through what the implications of that number are. Now, obviously, depending on what that result is, there's other investigations may be warranted. There might be more advice given at that point with regards to options, but to have that initial piece of information to kind of make a decision on, am I going to start down this rabbit hole, or am I just going to park this for the time being and think about it in a year or two's time?
And I guess as midwife manager, all you can do is lay out those facts, and sometimes they're not even facts. Sometimes I suppose they're estimates of different things, and then it is up to the person to be armed with that information and go away and maybe have a think about it, but you're there to inform them.
Exactly, and to kind of guide them with regards to, okay, you're 31, this is the number, that's fine. You know, that's within normal, you know, limits for what it is. Whereas you're 35, it's coming back a little on the low side. Maybe we'll have a conversation now about doing something sooner rather than later.
Claire, let me bring you in. I wanted to talk a little bit about male infertility, because I think it's something that gets completely sidelined often, and I have even known people myself and spoken to people that, you know, they might go down this journey for 6 or 7 months before they realise, actually, hang on, maybe the problem lies elsewhere. And it is often something that's not looked at at the beginning. It certainly should be. It takes two to tango, as they say.
The focus is always really on the woman, because she's the one having menstrual cycles. She's the one that has the negative pregnancy tests every month. So in a couple, it's often the woman takes it all on board, and we see that so many times. But we have to remember that if in any fertility cohort of people, 30% will be caused of their fertility factor will be caused by a female factor, 30% by a male factor, and 30% either unknown or a combination of both. Okay. So male factor infertility is a huge thing that we do need to take on board, and we see that so many times that, you know, the man is pushed in the door of our clinic, you know, by a woman who's after been trying for a year or, you know, longer. And then we find out there's a problem. Or in many cases, if a man has a child in a previous relationship, they assume, oh sure, you're okay, it's all my fault, you know, in terms of the woman. And then we can find out actually there is a factor here, because male fertility declines as well, and especially it's very prone to lifestyle factors and things like that, so it can go up and it can go down. I mean, if a man had a really good, you know, was very healthy in his 20s and had a baby back then, suddenly in his 30s maybe watching a bit more TV, or, you know, just puts on a bit of weight or something, that can affect sperm counts, and people never take that into consideration. prediction that maybe a sperm count can decline over time because of those factors, or maybe they're sitting more at work, and it's just some little things really that can affect male fertility.
So sperm could age in the same way as eggs can then?
Well, not in the same way.
deteriorate?
No, men make sperm all the time. So every day they make new sperm. Women start out with a certain amount of eggs and they never make any more eggs. So they're the same eggs you have from when you were born as to what you have today. Whereas men, they make sperm all the time. So it's very much influenced by external factors. So, you know, there's lots of research to show that hot baths, saunas, they all reduce the motility of sperm. So it can be something that just happens, you know, one day or for a week, and it affects that sperm then for about 3 months.
Aoife, do you find that maybe that there's a disconnect there when people come into you, if you're dealing with a woman and you might be giving this information, she might think, oh, well, he's not going to hear this or what, you know, that it's kind of, men often aren't as invested in the researching of this topic, maybe is probably the best way to put it, than women are sometimes.
There certainly is that factor. As Claire said, a lot of them are kind of show up at the door, kind of arms folded, don't want to be here, I've been brought along, I don't know what I'm going to do. And sometimes when it does show up that there is a male factor that might have been unexpected, it's like a eureka moment sometimes for men, and they tend to get more involved at that point. They tend to look at themselves, say to us, you know, look, I've not been going to the gym as much as I have been, or, you know, I've put on a lot of weight over Christmas, could that potentially have impacted things? Yeah, we say to them, of course, lifestyle is important, but we need to look at the overall picture of them as a couple with regards to what their best options are.
Okay, so Claire, let's come back to you then from a lab point of view, because you've got the expertise here. So say somebody comes, they find out their fertility age, they find out where they're at, they tell you when their plans are, when they would like to have a baby. You then obviously have to give them the information in terms of what they might do about freezing eggs. If this is something that's on someone's cards, they might hear from Aoife, their AMH, you know, their ovarian reserve they don't have endless years to do it, which nobody does. And that's then when they might decide that they are going to freeze some eggs. What's the first kind of step in that process then?
Well, the first step is to have a consultation with the doctor, and they will put a plan in place then that's appropriate for you. So once we know your level, your fertility level, your AMH level, we can then determine if freezing eggs is appropriate or not. So we can make a good guess at how many eggs we're going to get. We can never guarantee that, but we do like to get at least 10 eggs to freeze for somebody, particularly if they're under 35. So if you freeze 10 eggs and you're less than 35, you've got about a 70% chance of having a baby from those eggs in the future. If you're freezing eggs over 35, the chances go down, so you need to have more eggs. So maybe you need to do more cycles, more than one. Most people would do one egg freezing cycle and see how many they get, and hopefully that's it. You know, that's the guarantee for the future.
How many would they need then? If 10 is what you need, say, to give you the 70% under 35, if I was in with you at 38, what would you be telling me I should have?
To get that same 70% chance, you'd need to have about 15 to 20 eggs frozen.
Okay, so it's 2 rounds then of
most
egg
likely.
Okay.
Now, if you had a good AMH level, maybe we could get those 15 to 20 eggs in one cycle. So that's what I'm saying. It's all very dependent on the woman and her fertility status at that particular moment in time.
Now, most people listening or watching will think 15 eggs, you only need one. But tell us maybe a little bit about the process then of what can happen to a potential 15 eggs that are initially retrieved.
Exactly. So when you retrieve 15 eggs, let's say, 1 or 2 of those, or maybe more, might be immature. So in order to fertilize, the egg needs to have a certain maturity level. So we'll always collect some eggs that are immature. So they just come from the smaller follicles on your ovaries. So when we stimulate the ovaries to produce those eggs, some will grow faster than others, but we'll still collect all of the fluid from the ovary to see what's in there. So let's say you might lose 1 or 2 on that initial day, so you might be down to 13. Then we'll freeze that 13, let's say that magic number, freeze those eggs, and then in the future when we thaw them out, we might lose 1 or 2 of those again in the freezing and thawing process, because even though freezing and thawing is exceptionally good now, it's not guaranteed that they will actually survive. So in the future then, those eggs need to be inseminated with sperm, so either from a future partner or a sperm donor, and then they need to fertilize. So in order to fertilize, the sperm and the egg DNA must come together, and that's completely down to nature. So some people will get 100% fertilization. The average is about 50 to 60% fertilization. So you might be down to 6 or 8 eggs then at that stage, and that's even before they start to develop. So we monitor the development then for 5 days in the lab. in the hope of getting 2 to 3 what we call blastocyst stage embryos. So they're your day 5 embryos. So they're the ones that we will transfer back to your uterus. So we transfer one back. So you can see every time you go through a different stage, you lose numbers all the way. And that's perfectly normal. That's how we pick the best embryo at the end.
So it's definitely quality over quantity. You're looking for the best embryo. Aoife, let me bring you back in then. In terms of if somebody gets to that point and they're going for their egg retrieval, talk us through the process then of how long they can be frozen for, or how much time do they have to kind of consider, maybe they might meet somebody, or maybe they might decide to go down the sperm donor route. Is the time endless, or?
In terms of the eggs being stored, they can be stored indefinitely and they can be thawed out at a future date. But in terms of female age, most clinics, including ourselves, will put a cap on what age we will basically allow someone to use their eggs up until. That's more to do with, overall health, general well-being. There's no point looking at eggs, freezing them in your 30s and leaving them there until you're 50. It's a conversation we have. So that's why when you freeze them initially, there's a year's storage in it. After a year, you'd be prompted by us to either come back to have a conversation or to continue storage. And it's just to keep that conversation open. A lot of people might say to us, I've actually met someone, we're going to try naturally for a little while, and that's absolutely fine, and they can obviously conceive naturally at that stage. So the eggs that they've got with us in storage are their insurance.
So it's an insurance policy, exactly. Somebody who may have frozen eggs at 30 had no reason to think that they couldn't get pregnant naturally. They may have just very much done it as an insurance policy. We talked before about, different couple makeups, and I suppose you're dealing with people a lot of the time in ReproMed, and I'm sure you're seeing an increased number of people who are deciding to take on this journey or go it alone. Is that different, say, maybe when you started working in the industry? Have you noticed a big change in that?
I have, yeah, definitely. I'm about 8 years working in fertility now, and back when I started, it was mostly heterosexual couples, a man and a woman who'd been, trying to conceive themselves for a little while, sometimes longer than they should have been. Whereas now, I think people are more informed. They do tend to look for help that little bit earlier. We obviously have a lot of single women coming through that have decided that, this is something that they want to look at doing themselves. They haven't met Mr. Right, or, they just don't want to put it off any longer. We have same-sex couples as well who would make up a good proportion of our patients coming through as well.
So it's really changed, and I guess in ReproMed the key is to move with those changes, and for everybody in as much as possible to be treated as the same as they come through the doors.
Yeah. As soon as they come into us, no matter what their background is, whether they're single or in a relationship, they're all treated as the unit that they want to be treated with. So it's either as a single woman or as a couple, be that same sex or be that heterosexual, and we look at the overall picture of their family unit to try and adapt our care to them.
Is it common for men to freeze sperm?
While there is a decline in male fertility with age, it's not as drastic as the decline in female fertility. And there are more techniques that we can do if we have a male factor problem. So if a man has a reduced sperm count or reduced motility, so that's the ability of the sperm to swim, we can do different techniques in the lab to overcome that. We can't do the same with eggs. So when we get eggs into the lab, what they are. We can't do anything to improve the quality or anything like that. Whereas with sperm, we can do techniques such as ICSI, that's intracytoplasmic sperm injection, where we can pick a good sperm down the microscope and inject that into the egg.
So you're giving it every helping hand to get where it needs to go. ICSI wouldn't have been around. It's relatively new, is it, a treatment? I guess for people maybe who get news that a sperm count is very low or motility isn't great or mobility, that kind of it covers that off or could solve that problem.
Absolutely, yes. There's so much more we can do on the male side of things. So if we find a very severe male factor, then we will freeze sperm as a backup. So some men might have as low as 1 to 2 sperm per sample, and it gets that low, whereas a normal sperm count would be about 15 million sperm per mil of sample. So you're into huge numbers, but it can go right down. And with those men that have very, very low sperm count, we will do that ICSI procedure for them.
Claire, talk to me a little bit about when you get into the zone of donor egg, because I think probably for a lot of women, like speaking as a woman, I think that's probably maybe a shift in the crossroads. So, you know, you might embark on a journey of fertility. The hope probably is at the start that you will have a baby from your own eggs. And I guess you have to go on a separate journey then, maybe when you realise that that's not going to happen. And then either this is something that you will want to do or it's something that you won't want to do. How hard is that?
Yeah, that's a very difficult one because everybody sets out with the intention of having their own genetic baby. And it is a very hard thing to accept that, okay, maybe this is not going to happen. But luckily we have the option of donor egg. So these are eggs collected from young donors in their 20s, and they have a really, really good potential. So they're, you know, chromosomally, hopefully normal. You know, they've got a much higher chance of success than an egg that is 38, 39, 40 years old. Because the key to this is that we're all born with our eggs. So if you're 39, your egg is 39. If you're 32, you've got a much higher chance of success because your eggs are that much younger. And that's why egg freezing has such a good potential, because if you freeze your eggs at 32 and use them at 39, you've got the same chances as a 32-year-old. Yeah.
But I guess just at that point then you come into play in terms of explaining all of that to a patient, to a woman, you know, normalising it as such, or at least giving the information out there that this is something that is used by many, many people, and that option is there for them if they want it.
Exactly. And as you say, it is normalised now, you know, so many more people are availing of this. 10 years ago, it was quite hard to access information on donor eggs. Now it's very, very commonplace in our clinic. You know, we've got a really good program set up whereby we can send out the male partners. So either if you're doing it on your own, we can either send out the donor sperm or we can get a donor for you. But all of the eggs donated that we use at ReproMed are all donated in the Czech Republic. So they will create the embryos out there in their lab and then send them back to us in Dublin. So you never actually have to leave the country. So the process is so much easier now than it used to be.
Absolutely. And Aoife, I'm sure the science is mind-blowing for people sometimes because, you know, nobody's an expert. You guys are the experts in this, but when people come into the clinic, they probably have a very basic knowledge of, I'm here because I have to be here, I'm here because things aren't working out. They then jump on a massive learning curve where you do an awful lot of research yourself and you kind of do become what you think is a mini expert. But I guess when you're telling that information to a lot of people, it must be very comforting to them, probably overwhelming at times though as well.
It can be very overwhelming. Like there's a lot of patients come into us and they mightn't even know the natural menstrual cycle and what's the best time of the month to get pregnant. And that is unfortunately true. I think kind of sex education in Ireland is a little bit lacking anyway. They'll come into us, we'll have the conversation, we'll look at the whole system of how long they've been trying to conceive, have all of the options laid out to them on the table before we decide to do any treatments. So we are kind of holistic in that way, in that, you know, if someone's come in, they've been trying for less than 6 months, they're fairly young, no obvious fertility factors, we don't necessarily have to jump straight into treatment. But yeah, down the line, the information starts to build. And if you are on a fertility journey for a while, you know, you'll come in, you'll get the basics, you'll start to research yourself. That will open more conversations the next time you're coming in to see our team. So we do have that nice little, we've a very small nursing team in ReproMed, and everyone will get to know the patients. You know, you'll know you're going to meet one of 3 of us when you come in. You're going to be able to have that conversation quite openly, and it's in a kind of professional friend capacity at that point. I think it makes it a little bit easier when you are starting to look at jumping into those more advanced treatments, potentially looking at, you know, donor egg and those, you know, kind of advanced treatments.
What are the main concerns when people get to you at this point and they're on the journey? What kind of fears do you hear? Because I guess you're seeing them probably the most in the clinic, and if there is that kind of professional friend relationship, that you're probably going to hear their worst fears. What kind of things do you have to deal with?
There's obviously the fear of it not working, and that's always there, and we just have to really set them up for a fall. Managing expectations is huge. You know, just because you're coming in, you're doing the treatment, you're taking the medications, doesn't mean, unfortunately, that you're going to have success. And it's to kind of cushion that. Like, our success rates at the moment are phenomenal. They're well above 60% across the board, but that does still mean 4 out of 10 women that walk through our doors are not going to walk out with the result they want. I think from when they're starting treatment, the fear of the medication is huge. So that's why we'd meet with them one-on-one, go through all the medications, you know, teach them how to self-administer them. They're all designed that they are for self-administration, but people kind of think, oh my God, needles, when in actual fact, they're all injected into the tummy. They're all very straightforward, very little mixing or anything involved in them. They're all very modern at this stage. The other barriers we kind of have to get over is how we scan and how we monitor. So especially if you're doing an IVF cycle, we would be scanning regularly, and they're all internal scans, and they have bloods done with every appointment. So if you come into us with an absolute fear of needles, having to lie down on day one, probably by the time you get out the other end, you don't have any problems.
Yeah, you just get used to it. It's just probably one of those things. Claire, talk to me a little bit about money, because this is the other thing that people will always wonder, whether it's a journey that they're doing as an insurance policy, like we talked about, somebody in their 30s who might decide to freeze their eggs, or whether it's a couple who've been trying for a year and a half, and they decide that they kind of know now that they're going to have to ask for help. What kind of cushion should they have? What expectations should they have in terms of how much money this is going to cost them?
Yeah, it's always a big consideration for couples, as you say, for single women, anybody coming through. So in general, our costs start at about €3,000. That's to freeze eggs. If you are with VHI, you get a discount in ReproMed, so that's €1,000. So that is quite a significant saving off the €3,000 to freeze one round of eggs. For IVF, it starts about €4,000, depending on, what kind of, we always call them extras. They're not really extras, but, there's different things that might be needed
along
for
the road, I guess, that might happen.
And if you need that ICSI procedure, it's probably closer to €4,500 or €5,000 for the cycle. So realistically, people need to have, let's say, a ballpark figure of €5,000 to embark on a journey of IVF.
And I guess, if you take the statistics and if you look at them properly, there will be a lot of people who will think that they should embark on it when they can maybe have the cushion of doing 2 rounds or 3 rounds. Now, I know probably people take a break in between, reassess where they are, go back and look at their finances. There's probably, merit in doing that as well. Is that, Aoife, something that you might get asked a lot? I'm sure you see them maybe when they get the news that they haven't had a positive pregnancy test, or they come in for a blood test and it doesn't show a good reading. Do you advise in that way, or just give them the information then that...
It's really patient-led at that point, and their individual circumstances. Finances, unfortunately, are a huge burden and a huge block to treatment. Some people will want to go immediately and will, want to go straight into another treatment cycle. From our perspective, whenever you're ready to go, you can go. So if you take a month's break, get yourself together, even, from the financial side of things, then we'll be ready to go when you're ready to go again.
And Claire, there's no scientific reason to give yourself a break? Is that kind of one of those things that you hear, take a break and regroup? You could just do it the next cycle.
Just go the next cycle again, yeah. There's no reason to have to take a break. From the scientific side of things, it's not going to make any difference.
In terms of medication, you talked about people having a fear of what might be involved, and that it's made quite easy. Is it expensive though? Is that a concern that people have?
The medications in Ireland are covered under the Drugs Payment Scheme card, which is the DPS. So that's capped. There's a monthly fee. I think it's around €124 at the moment, and basically the fertility meds will be covered in that. So it does make it a little bit easier for patients to decide to go ahead when the medications are that little bit more affordable than if you were to buy them outright.
The other thing, I guess, that we talk about lifestyle changes and people are so busy in the age that we're in terms of time off work, what are you trying to give people an estimate? Are you trying to make sure they have a realistic expectation of how often you're going to have to see them and how they're going to put all that into their schedule?
We facilitate patients as much as we possibly can. So we start our scanning at 8 a.m. to facilitate those early morning scans so that you can go to work, and we won't delay you. It'll be literally the scan, a blood test, and you're on your way to work again. If you're having an IVF or an egg freezing cycle, you can expect at least 3 scan appointments. So, that'll be 3 days where you're either late to work or, you do need to attend to us in the morning. But as I said, we will get you seen as soon as possible. And the big appointment then would be the egg collection. So that's either when you're freezing your eggs or when you're having the IVF or ICSI cycle. You do require the whole day off for that. So that's your 4th appointment. And when it comes to embryo transfer, if you're having an IVF cycle, again, that's a very, very minor procedure. So we do those in the afternoon. So it might be a half day off work or that. So realistically, you don't need that much time off work, but we will, help you out as much as possible on that.
Aoife, what can people expect to feel after one of those procedures? Because again, we have to assume that there'll be people who will be going into this who will be squeamish about certain things and wouldn't like to put themselves through certain procedures. And I know when you want a baby, most people will do whatever they need to do, but I guess it's good for people to know maybe what to expect.
So the egg collection procedure itself, after all the hard work that goes into it, is over very quickly. Okay. It's only about half an hour. We sedate patients for that. Now, it's conscious sedation we use, so they are awake. Some people do sleep, but a lot of people will talk but remember nothing of what happened. The egg collections are done like you would be having an internal scan, and generally 20 minutes, half an hour, they're back in recovery asking, is it done? Afterwards, sometimes you can be a little bit queasy after the sedation because we will have asked you to attend fasting. So tea and biscuits as soon as you're feeling up to it before you go home, and then once they've mobilised and have gone to the loo and everything seems to be back to normal, they're ready to go home. Generally, they're discharged within an hour of the egg collection having taken place. So
it's quite simple, even though an awful lot of work and timing and all of that goes into it at the start. In terms of going about your normal business then after a procedure like that, you're the person who'll be giving advice to people. People might think, do I need to wrap myself up in cotton wool? Do I need to not leave the house? You're giving that advice. What is it?
After sedation, we say just go home and take it easy for the rest of the day. You are going to feel a little bit not yourself, a little bit hungover, maybe a little bit kind of drunk, is a lot of the feelings that we hear people saying, that they kind of go home and kind of can't remember what's going on. The next day you have to be careful as well, because after you've been sedated, it's 48 hours before you can actually drive again. So we just kind of warn people that if they're going to work the next day, which a lot of people do, either get public transport or get somebody to drop you in.
So just to bear that in mind, maybe in terms of planning. I suppose though, Claire, you can't plan a lot of it, because I know when you're on the roller coaster, it's out of your hands. So you might have your plan for the month, you go for a scan and you guys are saying something different, like you're ready, you're not ready, you need another day, another 2 days. So it's kind of, I guess, a month or a couple of weeks where I suppose the best advice is probably for people just to know that it's out of their hands and let you guys lead it and go with the flow, like in terms of what you might be told on a particular appointment. So
we always aim for, we'd estimate that maybe your egg collection is day 14, but it could happen on day 10, it could happen on day 12. As you said, we just don't know until we do the scans, and that's why we have to do those scans so that we can predict when is the best time for you to have your egg collection, because we don't want to collect the eggs too early and we don't want to miss it, because if you ovulate naturally, then all the eggs are gone. So we need to get in there just at the right time beforehand, and that's different for everybody.
And again, not an exact science, it very much is different things. You could do the exact same thing 1 month and then the following month it might work, it might not have worked, and I guess you can't explain the reasons behind that. Customers or clients probably find that a little bit hard sometimes, do they?
They do, but they have to remember it's nature. We can't control nature, so we can't control to a certain extent how your body reacts to these medications. We do our best to control it, but sometimes it's out of our hands as well. So that's why we would always say, allow at least 2 weeks of kind of up in the air, not really knowing, and then after that, that's it really. As Aoife said, the procedure is very quick and straightforward, and it's all done once the egg collection procedure is over. That's the biggest event in this.
So cycle. If somebody isn't necessarily up against the clock, and if they were looking at the difference between doing it in December or January, maybe go with pick a month where maybe it's quiet, you don't have a whole lot on, you can come and go as you please, and you don't have too many commitments.
Look at your calendar, look at your work, see, we're going to ask you to be available to us at potentially short notice for probably about 2 weeks, and sometimes it can be difficult for patients to know that and to kind of not have control of it. So we kind of say, whenever the schedule is cleared a bit, whenever work has calmed down a little bit, let's talk then and let's look at it then.
And obviously, that when you're not away on holiday or you're not out of the country or whatever the case may be. Aoife, do you find that, I suppose it's quite a sensitive topic. I think we are speaking about it an awful lot more, which is absolutely great. But there are lots of people who will want to keep their fertility journey private. So you might be the only person that they're meeting. They may have mentioned it to their parents or or one friend, but often people will keep it quiet until they know what the end result is. So I suppose for you, it's a big part of your job to be that friend or be that confidant for them.
Yeah, and that is very true. An awful lot of patients won't disclose to anyone that they're going through treatment for whatever reason. There's a stigma around it, and it can often happen that you are the only one that knows what they're going through. They're talking to you, you know, on a practically daily basis at some stage during the treatment cycle, and you need to just be there for them and be able to guide them through as best you can. I suppose we are quite well placed in that we know what we need to tell them, we know what to expect. So if I'm scanning someone this morning, I can tell her nearly immediately, okay, your follicles are this size, you're going to be back to me for a scan in 2 days' time, your egg collection is probably going to be by the end of the week.
So you can give that information. Yeah. And obviously an absolutely wonderful job on the good days when you're given that good news, whether you're ringing with embryos or your, good blood tests or whatever the case may be. But I guess you probably have to dig deep on certain days when you're bringing news that isn't going to be well received.
Yeah, it can be very hard. And, the highs are high and that's what keeps you going to work. But sometimes because we are such a small clinic, we get to know everyone so well, it can be a really devastating blow for staff as well when a cycle hasn't been successful, and we just need to really try and help the patient through that and see what we can do next.
And as you say, success rates at an all-time high.
They're excellent. Yeah.
Okay, Aoife Corley, Clinical Midwife Manager, and Claire Moran, Laboratory Manager, thank you both for joining us today. That's all we've got time for in this episode of Fertility Matters. You can head over to ReproMed.ie for more information, to make an appointment, or indeed to speak with one of the expert team, or follow ReproMed Ireland on Facebook, Instagram or Twitter for more information.
Fertility Matters, Ireland's newest fertility podcast, brought to you by ReproMed.